Next, I'm going to introduce Dr. Brian Snyder. Dr. Snyder is a neurosurgeon. He is part of Neurological Surgery PC. Their flagship hospital is Winthrop. Dr. Snyder trained in neurosurgery at Mount Sinai and then did a 2-year fellowship in surgical treatment of movement disorders and epilepsy in an outstanding center in Toronto, Canada. So with that, and trying to stay within the time limits, I'm going to turn the mic over to Dr. Snyder.
Thank you. I'm going to try to forego the mic because of that. So if I'm not loud enough, everyone, you can just tell me to talk louder. I'm not, don't be shy. So just so I have an idea, how many people here are Parkinson's disease patients? If you could raise your hands. And how many of you are caregivers or loved ones of people with Parkinson's disease? So it's a good mix between the two. And obviously both of you have different trials and tribulations I'm sure you go through every day. So I'm going to try to focus a little more on the surgical aspects of things. But we're a team, and so we all try to participate in taking care of all of you. And no one person alone is able to do everything. So the title of my talk is about DBS for Parkinson's disease, regain your lost independence. So I see surgery, it's not a cure as we've discussed, but it might be a chance to regain some of what is slipping away because of the disease. So we'll cover some of the facts about Parkinson's disease. We'll talk a little bit about deep brain stimulation, and then I'll touch on some of the other treatments that are currently being studied. Someone's telling some jokes next door, you can hear. I'm probably not as funny, but I'll try. Okay, so our team. So as I mentioned, it's not just me, and it's not just Dr. Bajaj. We can't do this alone, and we wouldn't want to try to take care of you alone. We have a big team, and if you come to be treated at Winthrop, you'll meet different parts or all of the team depending on what your needs are. So there's always a movement disorders neurologist. That you've heard from her already. There's myself, I'm the movement disorder or functional neurosurgeon. We have a team of physical and occupational therapists. Some of you might be deconditioned. Some of you might need more help just learning to walk again or learning to walk properly given your new limitations. We have social workers. They can help you. They can help your loved ones to figure out how to get you to the doctor's office, how to get the medications or whatever other needs. We have dietitians. Some of you might be having trouble feeding yourself. Some of you might have questions as to, well, what should I be eating? Because they say this isn't good because of my heart medication. My neurologist says this isn't good because of, this medicine interacts with that, and I want to eat healthfully, etc. We have a neuropsychologist or a team of neuropsychologists we work with. As we alluded to, one of the concerns with surgery, but it's a concern anyway, especially in an older population, is that some of you might not be thinking as well as you would hope to. We want to identify those problems and try to help you with them. We have neuroradiologists. So anyone that's having surgery is going to have another MRI of their brain. We want to make sure that we have no clues to suggest you have a different disease, that there's something else we could do to help you before we embark down the road to surgery. We have neurophysiologists. So if and when we do surgery, we listen to the cells in your brain to find the sweet spot, to find the spot to put the electrode, and the neurophysiologists help us. And we have anesthesiologists. So anyone that's having surgery needs to be safe to have surgery. So we have medical doctors see you first and say that you're ready for surgery. And we have anesthesiologists skilled and comfortable working with Parkinson's disease patients, doing the operations that I do so that they can help you as well to make this all as pleasant and painless as possible. So what is Parkinson's disease? Again, so this is an illness in the brain that gets worse over time, and it leads to problems with movement. The cause of the disease is not known, but what we know is that people with Parkinson's disease have degeneration of cells in the part of the brain called the substantia nigra, and those cells secrete dopamine. Dopamine might sound familiar. Levodopa is synthetic dopamine. So what is Parkinson's disease? Again, we're going to see if this is turned all the way up, and we're going to just listen to this slide for a second.
The microphone is by the screen if you want to hold it next to the platform.
Give me 1 second. I'm sorry. Well, let's just...
one important structure within the basal ganglia,
We
produces a chemical known as dopamine. Dopamine is transported to other areas within the basal ganglia, and this enables the coordination of smooth and balanced muscle movement. Parkinson's disease causes the cells in the substantia nigra to die, which results in less dopamine within the basal ganglia. This results in the motor control symptoms associated with the disease.
Okay, so the facts about Parkinson's disease. So there's four main motor symptoms we talk about. We talk about tremor, we talk about rigidity, we talk about akinesia and bradykinesia. That's being slow or having difficulty moving. And then we talk about postural instability or poor balance. I'm sure many of you relate to any one, or if not all four of those. And then we talk about the side effects of medication. So for a lot of patients with Parkinson's disease, while the medication helps, it's almost as much of a problem as the Parkinson's disease itself. You take the Sinemet, you feel great for a bit, and then next thing you know, you're moving uncontrollably, you're having what are called dyskinesias. So it's always a problem trying to treat you properly and still not have these side effects. So we talk about motor fluctuation. So as Parkinson's disease continues, you have motor fluctuations. So we talk about wearing off of the medication. So you take your Sinemet, next thing you know it's like you never took the Sinemet at all. It could have been a tic-tac. So you have sudden unpredictable swings from good to poor movement control. So again, you're doing well, and then you're not doing well. These are common problems. So about half of patients with Parkinson's disease develop motor fluctuations between 5 and 9 years after the start of Sinemet. And as Parkinson's disease progresses, many patients develop this despite optimal medical therapy. So despite the best drugs being managed, this still happens. So how many people in the room have problems like this at this time? If you want to raise your hands, if anyone's having problems where they feel like your drug isn't behaving like it should be or isn't behaving optimally. So there are a couple hands in the room. So this is obviously one of the problems we deal with. So dyskinesias. So dyskinesias are excess or involuntary movements that occur. And these often occur when the medication dose is too high or when the medication dose is normal, but the body is perceiving the medication dose as being too high. It can also occur as the dose wears off. 4 out of every 10 patients with Parkinson's disease develops dyskinesias, again, from about 5 to 9 years out. That's when typically these things start to develop. And as Parkinson's disease progresses, similarly, many patients develop dyskinesias despite optimal medical therapy. So despite being on the right drugs, dyskinesias become more and more prevalent. Again, just to poll the audience, how many people have problems with dyskinesias? So a few more hands go up. These become increasing points of burden for patients with Parkinson's disease. So quality of life. So Parkinson's disease is a disease, and we learn to live with it, but we also learn that we have problems with quality of life, that our lives aren't exactly the way they were before. We took the microphone away, so we'll see if we can hear what this slide has to say. Just give it a second. So this is a patient actually that had surgery by Dr. Rezai in Cleveland, and this is the patient's family having a conversation. So this is the patient on with medication.
Surrounded his medicine and his good time. If he didn't have good time, we couldn't do anything, and even then it got to the point where you might get in a restaurant, but you couldn't get out. So, because his medicine quit working, and he couldn't walk. So sometimes you just didn't go because it was easier to stay home than to go.
I was taking a pill every 2 hours. And sometimes the pill would work, and sometimes it wouldn't. And when it worked, I had about an hour of good time, which meant the half hour that I waited for it to work, and a half hour before the next pill was down. So I really only had 1 hour of good out of every 3.
He needed help at times. He got to the point where he didn't need unless he was good. Unless his medicine was working, he didn't need.